Right. Okay. Right. Okay. Hello, everybody. I welcome you to the Radiation Oncology webinar. This is being brought to you by the American College of Radiology Radiation Oncology Education Committee. This webinar series seeks to inform you about emerging technologies, treatment techniques, and hot topics in the field of radiation oncology. This is your host, Hina Saeed. I'm an assistant professor in the Department of Radiation Oncology at the Medical College of Wisconsin. A few items before we start. This session is going to be recorded. We ask everyone to please turn off your cameras and keep your devices on mute during the presentations. During your Q&A segment, all attendees or participants will have the option to interact with the presenters by clicking their hand raise icon to be unmuted, or use the chat feature to submit questions. So this webinar will focus on radiation oncology advocacy efforts and ways to leverage the resources of organized medicine groups such as the ACR to advocate for the best oncologic care for your patients. The recording will be available on the ACR Radiation Oncology Resources webpage and ACR Radiology YouTube channel within 48 to 72 hours of the recording. The goals of the webinar include education of our participants regarding the different avenues for advocacy in radiation oncology, to provide and outline practical ways to get involved in radiation oncology advocacy, and to highlight the benefits of ACR membership with regards to advocacy. So it is my pleasure to announce our first panelist, Dr. Amar Rewari. Dr. Rewari is a radiation oncologist at Adventist Healthcare Radiation Oncology Center in Maryland. He is an emerging leader in healthcare policy and payment reform in the field of oncology. He is a chair of FASTRO's Co-Development and Evaluation Committee, the AMA RUC Alternate Advisor, and chair of a work group developing a radiation oncology APM for Maryland's Episode Quality Improvement Program. Our second panelist is Dr. Wallner, who needs no introduction to anyone in the field of radiation oncology. Dr. Wallner is currently the Senior Vice President for Medical Affairs of 21st Century Oncology. He has served in various leadership positions in ACR, ABR, ASTRO, and ACRO, and also has represented ASTRO on the CPT, RUC, and APC committees. Now, without any further delay, I will turn it over to Dr. Wallner, who will give an introduction to advocacy in radiation oncology.
Thank you very much, Hina. What I'd like to do today is to give you a little bit of an introduction to advocacy, and then Dr. Rewari will speak about some specific issues. Basically, unless any of you are billionaires or Fortune 500 CEOs, you'll generally be working with or for an organization. And what I'd like to do is spend a little bit of time talking about how to go about that, how to get involved, and really how to participate. Well, nothing's advancing. Oh, there we go. Okay. Physicians and scientists have traditionally not been very interested in getting involved in advocacy issues, but it's critical that you do that. It's really not unseemly. It's appropriate to argue for causes in which you really believe. The second bullet point is unfortunate, but it's true, and it's not a pejorative. It's neither good nor bad. It's simply a fact of life, that when a piece of legislation or regulation is written, invariably there are winners and there are losers. And if your position has not been heard or stated, the chances are you will be among the losers rather than among the winners. Advocacy certainly doesn't ensure that you will win, but if you don't advocate, it pretty much ensures that you may lose and certainly reduces your chance of winning. And one of the things that's absolutely critical in advocacy once you get involved, and it's difficult for physicians who are used to making decisions and acting upon them, But once you're involved in advocacy, you have to be patient. Patience is a virtue. Some of these issues, and I'll talk about that in a little bit, some of these issues can take literally a generation to evolve. All you need to do is read about the history of Medicare development to see that it really was a 50 to 60-year process to get Medicare enacted. Not advancing. Okay, there we go. Once you get involved in advocacy, there are really three levels that you can consider: local, regional, or national. You can do one or both or all of these different levels. And frankly, a lot of this begins at the local level and percolates up. When you deal with legislators, typically they're more involved with overriding policy decisions and often they're major and multifaceted decisions, rarely operational decisions. Legislators more often will drive budgets and allocations of those budgets. So more often you want to talk to the legislators and work with the legislators about major overarching issues. Regulators are more inclined to deal with targeted policy, and they essentially operationalize issues that have been enacted by legislation. And when I talk about specific details, what you'll see in most pieces of legislation is the quote, and often it's the secretary. So very often involved in our affairs, it'll be the secretary of HHS shall. And what the shall is enact or develop, promulgate certain regulations that will then operationalize the legislation. So more often than not, we are dealing with legislators for global issues and high-level issues and regulators for more detailed issues. And that they are differences, major differences in how you approach legislators and regulators and legislative staff, which is more common than actually dealing with legislators. And then partners. We have partners in various advocacy groups, and you shouldn't minimize those partnerships. They may be more specific to their own agendas. We may relate to partnership organizations for certain very specific issues, but not for other issues. We may agree with organizations for certain issues and not for other issues. And a good example of that is the AMA. Very often we disagree with the AMA about certain issues, but work with them on very targeted issues. And working with partner organizations are very important for leveraging your resources, whether it's leveraging staff, leveraging dollars, and leveraging outreach to some of their advocacy groups. Approach to advocacy is critical. You have to know your audience. Sometimes it's general versus a very specific issue. I'm not so inclined to advocate for general issues, things like the benefits of research, because basically every organization in medicine or every organization in healthcare is doing the same thing, but very often that is critical. We're more interested in specific issues that may not relate to some other organizations or specialty organizations. You have to also know the level of influence of the group you're approaching. Specific organizations may not relate to issues. You may not want to deal with a legislator involved in a specific lower level reimbursement issue. That may be totally the realm of regulators. But the key, aim as high as possible. As we taught my daughter when she was dealing with consumer issues, aim as high as possible, in the sense that you never want to deal with somebody who's not authorized to say yes. That may seem simplistic, but very often you'll be dealing with lower level individuals where you'll never get an answer. They'll say they'll get back to you. That's very common, especially when you're dealing with staff individuals. Do your homework. That's critical for regulatory advocacy. When you're dealing with regulatory staff individuals, very often these people spend their entire careers dealing with some of these arcane issues. They know more than we do about most of these issues, but it's critical that you do your homework and are prepared even with legislative staff people. When you're dealing with legislative committee people, they're very well prepared because they deal with healthcare issues all the time. When you're meeting with legislators, staffers, they may not even be related to staff issues, especially if a particular legislator is not on a high-level healthcare committee. So you want to know who you're meeting with. Focus your discussions and limit the asks. Very often, people who prepare you for these will say, don't ask for more than 2 or 3 things. They won't remember them anyway. And really, it's critical that you focus what you're asking for and it be very specific. Personalize and humanize where possible. Don't be intrusive. I've had legislators or regulators relate to me that they have a family member or a friend who has a specific malignancy. And then you can, if they raise that issue, it's perfectly appropriate for you to say, how can you be of service, or what questions do they have? But don't deal them out. Have you ever had a malignancy? Have you ever been treated for a cancer? That's an inappropriate question unless they bring up the issue. Wherever possible, leave materials, offer to be of service to them, offer to meet with them, to answer questions, to give them tours of facilities in their districts, offer to be of any help you can, and be patient, especially with legislators and regulators. I can't remember in 40+ years of dealing with this where I've ever gotten an answer to a specific question at the first meeting. Very often what you'll get is, we'll get back to you. Don't push them on that. That's for the most part what all they're prepared to do. And very often the legislature will say, I'll be happy to help. Don't ask them specifically what they mean by that. You don't want to push them on their level of support. People ask, how can you get involved? Well, follow legislators' social media, go to their events, deal with their issues. Don't overdo it with comments and thumb ups and friending them, whatever that means. I don't do that with any of them. I try to do one-on-ones with them. I try to speak to them as much as possible. Sign on to legislative and regulatory updates. Reach out to the ACR Government Relations Committee, and I'll talk in a few minutes about how you get involved with that. This is a key issue. The second major bullet: support your friends. And when I say your friends, that's our friends in general. If available, utilize state PACs or directly donate to campaigns. Offer to host a fundraiser. I can't tell you how important that is, to allow a fundraiser to use your home, or if you have a community center in your community, allow them to use that for a fundraiser. That's critical. That's the way to get to know them. And even more important, when we use that $, is if you can be a bundler. And what that means, and I'll talk about funding if we get to that later on in the discussion, but bundlers are people who put together fundraisers to have a greater amount of dollars. Being a bundler, it gives you incredible access to some of these legislators. The ACR is an incredible resource for advice and strategy and historical context. Remember, many of these things go over multiple legislative sessions, go over multiple Congresses. The ACR has the resources to provide historical context. What happened, who supported a bill, who didn't support a bill, what legislators you can look to for support, what legislative districts have changed and now have different issues involved. They keep you up to date on issues and topic-specific resources. They can give you reviews and critiques of legislative language, which we don't deal with this on a day-to-day basis, but ACR staff do. They can review regulations and give you significant information regarding regulations. They can give you incredible information regarding liaison with other specialties and other specialty societies, and more importantly, or as importantly, other specialty staff individuals. They can track bills and the nature of those bills and what's happening and what amendments have been tacked on. They can give you data regarding other resources, and Advocacy and Action provide you with email regarding some of these specific topics. The ACR is involved in critical advocacy regarding regulatory affairs, and I won't go over every one of these acronyms unless there's specific questions related to them later. You can write them down and I can discuss them specifically, but regarding regulatory research, some White House issues, and many international issues that ACR staff are involved in on a day-to-day basis, because of our, as they say to us, we all have day jobs, and their day jobs are being involved in these advocacy issues. So reach out to them and use them. That's what they're there for, and they're happy to help. As far as I'm concerned, the absolute best advocacy is personal relationships. It's interesting when you look at members of Congress, even in the leadership, most of them started in the local, whether it's a town council or somebody on library committees, some of them and mayor's races, and then they move up in the ladder of legislative affairs. But you get to know them at the local level and a personal level. I can't tell you how meaningful it was when I did an advocacy day with someone who you would all know, when a member of Congress who now happens to be in a leadership role in the Senate left his office, his private office, came out to greet us, greeted the individual I was with by name, asked him how his kids were by name, and I can tell you that he stayed with us for 20 minutes and listened to our specific issues. So personal relationships are absolutely critical. Get to know these members, but also get to know their staff members. Make sure they get to know you, and you can be available to them. The ACR has regulatory affairs contacts and government relations contacts. These people are absolutely stars in what they do. I can tell you that they are incredible resources for you. They're accessible, they're knowledgeable, they are happy to help. We'll make available these contact information for you after the webinar. RADPAC contacts are also critical. RADPAC is a critical resource because of the issues of access. Money, as I've said before, doesn't get you an absolute solution to your problems, but it does get you heard. And the RADPAC is incredible. Essentially, PACs are bundlers, if you will. It's just a different form of bundling to get your message across.
Thank you, Dr. Wallner, for such an in-depth overview. Next, I would like Dr. Rewari to share his expertise with us regarding advocacy in healthcare policy and economics.
Hi, everybody. Thank you. I first want to thank the ACR for inviting me, and Dr. Saeed and Dr. Lassis for organizing this, and obviously Dr. Wallner. As we all know, I actually remember when Dr. Wallner came and did a visiting professorship when I was a resident at Rutgers and talked about these issues not that long ago. So he was definitely inspirational in me pursuing this pathway. So can you move the next slide? It's not moving. Perfect. So I was asked to speak about advocacy for physician reimbursement, which is a much broader topic than just physician reimbursement, but actually also includes health policy and economics related to radiation oncology. And so everything I'm going to talk about, nothing's very special or unique about what I'm doing. It's there's been many people before me who've done exactly the same thing. The key is just, if you have a passion in this, and this is something you're dedicated to, if you're kind of like a policy wonk or into this type of stuff, this might be a good way for you to pursue your advocacy in your career. I kind of decided early on that if I want to look at advocacy and physician reimbursement, I'm going to try to focus on all the different touch points where physician reimbursement could come into play through the process. And that includes valuation, coverage, payment reform, and awareness and education. So I'll get into a little bit of that. So in terms of valuation, so, how do we get paid for what we do? And you know, everyone who's, whether you're working in private practice or academics, everyone knows about RVUs, right? And RVUs are how we're kind of valued on a relative scale compared to other specialties, and how what we do is valued. And so where do RVUs come from? Well, it comes from this cycle which you see here, the RUC cycle. The RUC committee is pretty much the RVU, the committee that sets the RVUs. And so your work, which you're compensated for, is based on the actual work, the time of that work, and the intensity of that work, as well as the expense associated with that work. And so how this works is, let's say a specialty has a new procedure they want to value, or a vendor has a new technology they want to value. If you start at the upper left, that first goes toward the CPT committee, who kind of decides if there is enough evidence to create a code for that procedure. Then once that code is created, the interest in the code is created, they send out interest, level of interest to any other society to see, do any societies have an interest in this technology or this procedure? So if they do, then they'll respond that they do, and they'll survey all their members in that specialty about how long it takes to do that kind of a service, what costs are associated with that service. So this way you could come up with like a typical scenario that could be valued for that service. Then it goes to an internal committee for that specialty that comes up with recommendations that then are presented to this RUC committee, which decides on whether those recommendations are appropriate and whether those recommendations should be accepted and moved on to CMS for valuation of the payment for that procedure. Next slide. So for the RUC, there's an advisory committee. For the advisory committee, there's 2 physician representatives appointed from all 118 specialties. So I and Dr. Kettle are both advisors for the specialty of radiation oncology. And so we assist and help develop and present these recommendations to the RUC. And the committee, the internal specialty committee that sets these valuations is actually based out of FASTRO. And it's the committee that I'm a chair of right now, which is the Co-Development and Valuation Committee. So that committee evaluates these proposals for CPT code applications, whether they be from vendors. Sometimes CMS that itself wants to revalue an existing technology. So let me give you an example. Like recently, proton therapy. Proton therapy has been carrier priced, and we were asked to revalue proton therapy. And so surveys were sent out to members who do proton therapy. We had to collect invoices of how much the equipment costed, how much vaults costed, how much time and effort went into the staff time for delivering proton therapy. And then we had to come up with recommendations which were presented to the RUC and then to CMS. And ultimately, as we see in the proposed rule that came out from CMS this week, that they maintained carrier pricing. And so that's kind of how the whole process works its way through for any technology in radiation oncology. And so these are the ways, if you're interested in this type of an advocacy for valuation, you could be involved through committees that are involved in this process. So once technology is valued and CMS decides to, let's say, approve the RVUs for a certain procedure, that's not the end of it. There's local coverage determinants. So Medicare splits up what is covered on a local basis into jurisdictions that are called MACs. And so here's an example. Here's a map of all the different MACs present in the United States. So I practice in Maryland, and so my MAC is the Novitas MAC. And so, slide. So how we can advocate on a local coverage level is these MACs have carrier advisory committees, which have 2 physician representatives, it's, Dr. Hughes and myself, and we look at the different coverages, coverage policies, and see is there something that's not being covered on a local level that we think should. An example of this is recently, a few years ago, the perirectal spacers for prostate implants. They were approved by the RUC and CMS, but certain of the MACs weren't covering them. And so we would get involved with advocacy through the CACs to promote that these spacers should be covered on the local level too, because there's good, robust data to support that. Another area where you can focus on advocacy in regards to coverage is directly with CMS. You can advocate or lobby to CMS directly about issues. And you can do that through both ACR and ASTRO, through committees who we draft letters and write letters and lobby. We'll have sometimes in-person meetings with CMS to discuss the issues. One of the recent developments, as an example, was the Office of the Inspector General recently came out with a report saying that simulation codes should be bundled in with 3D and shouldn't be separately reported or reimbursed, because that's how they're valued for IMRT through the RUC valuation process. But simulation is not bundled into the 3D planning payment. So that's an inappropriate recommendation from the OIG. And so we have been engaging with CMS, both ACR and ASTRO, to push back on this. Another area of engagement is with private payers. Sometimes private payers will choose to not pay for services that they should. For example, recently there's been issues related to 3D delivery treatments and IGRT has not been getting reimbursed. And so we've been reaching out directly to some of the private payers that have been not doing the reimbursement for those services. So payment reform is a big thing right now. So, you know, in 2015, MACRA, the law established the Quality Payment Program, the QPP program, which pretty much created a MIPS program, the Merit-Based Incentive Payment System, as well as the Advanced Alternative Payment Model System out of that program. And so these were a way to create value-based care, value-based medicine. That's been the shift over the last decade. In 2017, about 1/3 of payments in this country for medical services were done through an advanced payment model. And it's expected by 2022 that should reach about 50% for Medicare. So this is definitely the trend of where things are going. So, you know, CMS came out with a proposal for this national radiation oncology alternative payment model. And there was a lot of advocacy from, once again, ACR and ASTRO on how to look at this model. So the basis of an alternative payment model is that you look at base prices, which are based on historical prices, then they're discounted, and that's where Medicare would achieve their savings and CMS would achieve their savings. That discounted price creates a target price. And so if you, a practitioner, are able to achieve that target price or even below the target price, then you can share in some of that cost savings. If you exceed that target price, then you're penalized and you have to pay some sort of penalty. And so the national ROAPM is mandatory for a certain amount of practices in the proposal. There's penalties, there are incentive payments, there's a lot of different things going into it. So there's a lot to advocate for, because while we want value-based medicine, because we want to promote good quality of care, we don't want that just to be an excuse for cost shifting, where we're shifting from fee-for-service just to bundle, just to save money and not really improve quality. On a local level, some states are engaging in creating their own alternative payment models. For example, Maryland is excluded from the national model, as well as Vermont, I believe. And so certain states are looking at developing their own kind of systems for alternative payment models. And certain insurance carriers and private payers are looking at their own systems also for a bundled payment. In terms of the MIPS program, so the MIPS program has 4 categories, and one of those categories is the cost category. And the cost category pretty much also looks at how your expenditures compare to what it should be on a national average. For oncology, we don't have anything specific for radiation oncology yet, but there are committees such as the episode-based cost measure oncologic disease subcommittee through Acumen, which is looking at these cost measures. And so they had looked at lumpectomy and mastectomy, and what they decided for now was just to focus on surgical services as part of that bundle and not to focus on radiation oncology, but eventually radiation oncology will be looked at. And so these are also different areas where if you're interested in advocacy for payment reform, you could look at both the MIPS program to get involved in or through the APM program. And the last category is awareness and education. What I mean by this, I mean not only educating yourself, but also educating other members or making other members of the radiation oncology community aware about issues related to physician reimbursement and payment reform, and also other specialties aware, and broader public, as well as legislators like Dr. Wallner spoken to. So one of the best ways, I think, to get involved if you're interested in a lot of this, these policy issues, is to do a health policy fellowship. I personally did the FASTRO Health Policy Fellowship, but I know people who did the ACR Health Policy Fellowship and the ASCO Health Policy Fellowship, all who had great things to say about those fellowships. So this is a great way to get involved. There's coding and coverage seminars and coding manuals that you can be involved with, authoring and editing, or attending these seminars, and eventually being involved in speaking at these seminars to once again increase awareness so people know how to code correctly. There's a plethora of committees across so many different societies that you could be involved in to do this stuff, and subcommittees, work groups, also within those committees. So if you're motivated and you're interested in this, there's a lot of different committees to get involved in. Another way you can do is collaborate with your peers. Specifically, like in this time with coronavirus, there's been a lot of collaboration going on in the scientific community, but also in the policy community and the economics community, with people collaborating on webinars like such as this, podcasts, publications. So those are all good ways to be active and involved. And finally, as Dr. Wallner had mentioned, you know, engaging with your legislators is great. I find one of the best things to do is invite the health staffers for those legislators to come and do a facility tour. This way you can first give them a little 30-minute spiel about radiation oncology, let them know that 2/3 of every cancer patient is touched by radiation oncology, and so we're not some niche and that through this whole COVID crisis, we were a resilient specialty. While oftentimes medical oncology and surgical oncology had closed their clinics, you know, radiation oncology was the only way to achieve local disease control in these sites. And so, so if you highlight this to legislators, I think they're very impressed and they want to learn more. You can give them a facility tour, show them your fancy equipment, you know, and how you interact in a multidisciplinary fashion with your other specialties, I think is also important for them to see. So, yeah, thank you.
Right. Thank you, Dr. Rewari, for your very, very valuable insights. For our audience, please continue submitting your questions through the chat feature. We will move on to the panel Q&A portion. My first question is for Dr. Rewari. What is the greatest challenge facing the radiation oncology community in terms of advocacy for payment reform?
So that's, I think, that's an excellent question, Dr. Slade, because I think that is exactly what is the biggest challenge right now, is issues related to the radiation oncology alternative payment model. And the proposed rule, you know, 40% of practices were going to be mandatory enrolled into this model, and they were going to be randomly assigned based on what kind of population market they were in. And so there's a lot of issues nowadays with that, especially given COVID. You know, we'd be concerned with practices right now are having issues financially. And so to be mandatorily put into a model where there's uncertainty in regards to financial stability, and then to be penalized with penalties through that model, that could be a very scary prospect and can put some of these practices potentially under, and then patients won't have access to care. You know, during this year with coronavirus and everything going on in the pandemic, many of us shifted to doing hyperfractionated treatment for breast cancer and lung cancers and other cancers, which we historically wouldn't do. And so when we look forward and this alternative payment model looks back to what are the trend factors that will go into future years of base payments for the model going forward. If they base it off the year 2020, when everything's done in a hyperfractionated fashion, it might be an inaccurate true cost compared to when people are going back to their routine fractionation schedules. I also worry about vendors, particularly during this crisis. You know, vendors have also been hit hard, and so are they going to be able to update their software to make it compatible for reporting for the payment model in a timely fashion if CMS says we have to start next year? So these are all issues and challenges I think we'll have to deal with.
Sounds good. Would you like to add something to it, Dr. Wallner, or shall we move on?
No, I'll take a few moments for that. I think there's been a lot of consternation in the radiation oncology community at large about the potential for an alternative payment model. And let's be clear, when we're talking about an APM, we're talking about global payment, really, or episode of care. There are all kinds of ways of using nomenclature, but it's essentially global payment for, let's say, a course of treatment for definitive lung cancer. That has been sort of percolating for several decades. And I first raised the issue probably 20 plus years ago with Medicare, and it met with very little interest. The problem is, when I first served on the RUC in the late 80s, early 90s, it was very clear that radiation oncology was not a popular specialty. We were at that time, and remain, one of the last specialties in healthcare to use an unbundled payment system. And Medicare and the members of the RUC, the other specialty societies, were not especially happy about the fact that we could essentially control what our reimbursement was by increasing the number of fractions, increasing the level of technology. So we proposed to them, actually 20 years ago, a demonstration project, either in a state or a region or with a particular organization or a particular large practice, but there was very little interest in that. But I must say that one of the things that I've always been a proponent of, and I think we've gotten involved in this now, is to essentially go to them with a proposal that works for us. Go to the Congress, go to the legislators with proposals that work for us, which we're trying to do at this point in time with the APM system, rather than letting them develop a system that may or may not work well for us. So I think we need to be proactive in some of these reform measures.
All right, moving on to the next question. What advice do you have for radiation oncologists interested in getting involved in advocacy efforts? And why do you think they should be involved in ACR plus ASTRO as opposed to ASTRO alone?
Who would you like to take that?
You, Dr. Wallner, for first.
Okay. Well, as a basic concept, if you don't get involved, you have no right to complain. That's number one. The second issue is that it can be stimulating. It can be incredibly motivating. You're working with a lot of incredibly talented and motivated people, and it is a way to change healthcare as you believe that it should be changed. I think that the ACR offers an incredible amount. First of all, the organization is literally 10 times the size of ASTRO. That's simply a fact of life. It's not for good or bad. It is simply a fact of life. They have a much greater staff. They have much greater breadth and depth, they have a much larger budget, they have a much greater ability to interact with legislators, and legislators look at numbers. And when the ACR people are talking to them, they're talking about 30 and 40,000 members as opposed to 3,000 or 4,000 physicians. So I think there is an advantage. ASTRO obviously is speaking just for radiation oncologists. It's a much more focused discussion, a much more focused advocacy. How to get involved, Dr. Rewari related to this a little bit. I think you can get involved at the state level if you don't want to spend a lot of time away from home. If you want to get involved at the national level, you need to reach out to committee chairs, reach out to government relations staffers. These committees are always looking for volunteers. And if you're really, really serious about this, I would absolutely encourage those of you, especially younger ones, it's a little past the time for me, to consider a White House fellowship for a year, a Senate fellowship, a Robert Wood Johnson fellowship, a Sloan School fellowship. Those kind of programs get you in the forefront of healthcare change in this country. And once you go from a White House fellowship, you become a mover and shaker. And those people are known. That's how people like Zeke Emanuel got to be known. People like Scott Gottlieb got to be the head of the FDA. Those become the movers and shakers.
Dr. Rewari, would you like to add something to it?
I'll just also say, you know, I do think both societies collaborate and work very well together. And so I think you can be involved in both. And a lot of people are. The other things I think, beside what we've touched on in ways to be involved, is networking. I think within the community, and mentorship. I think, you know, I have mentors who I still turn to, and you know, I have people I mentor. So I think it's always a continuous learning process in our careers, right? And so mentorship's a great way also to be engaged and get into this.
I'd like to make one other critical point about the difference between the ACR and ASTRO. There are certain committees in healthcare that are critical to our working environment on a day-to-day basis, and Dr. Rewari can comment on this very well. The RUC committee, the CPT committee, those committees, the membership are created, they are AMA committees. Membership is created by the membership in the House of Delegates. The American College of Radiology has permanent seats on the RUC, permanent seats on the CPT Advisory Committee. ASTRO does not. To the best of my knowledge, in 1990, 91, 92, I was the only radiation oncologist who has ever sat on the RUC as a voting member. And that's because I sat there baking bread with those people for 10 years before that. But the fact of the matter is, ASTRO has no permanent voice on those committees where the ACR does, and that's critical. And by ACR involvement, I mean membership, not just ad hoc where one member of a 20-person department joins. You have to really join and stand up for what you believe.
Okay, well, that sounds good. Let's move on to the next question there. So in your career, what differences have you observed in the approach to advocacy by different oncology organizations? And that does not include ACR and ASTRO, but other ones like ACS, ACRO, ASCO. Dr. Wallner.
Well, my career goes back to 1969 when ASTRO was a club working under the ACR, and ASCO was a figment of the imagination of a couple of medical oncologists. The fact of the matter is, in the 60s and 70s, really into the 80s, the specialty societies, the medical organizations were not very involved in advocacy. We were more interested in science, technology, and in running meetings. But then once we saw that Medicare was getting more involved in day-to-day reimbursement, where we got away from the usual and customary reimbursement system to the relative value system, where getting involved in the trenches, if you will, made a difference. The specialty societies got much more involved. So now it's absolutely critical that individual specialty societies, that you get involved with your own specialty society, that you begin to relate to others where it's appropriate for you. And I must say, with the ACR and with FASTRO, there have been many situations where we disagreed with ASTRO or where we disagreed with the AMA, but in specific instances where we can work with them, where we can relate to them, where our initiatives and issues relate, I think it's critical. And over the years, I've seen us get from really sort of a volunteer effort as just anyone who's interested. And in the early years of these efforts, the ACR and ASTRO would very often reach out to radiation oncologists or radiologists who lived in the greater Washington region simply because they were local and they could reach out to them to get them to come to a meeting. But now it's become almost a pastime for some people, and they've become very professional at it. And that, I think, has been the big difference over the years, that people within these societies are very committed to these advocacy efforts.
Let's move on to the next one. Dr. Rewari, what role does advocacy play in your day-to-day clinical practice in radiation oncology?
So, you know, the thing about how I use it day to day, I guess, would be, you know, for example, I come across issues that I can see in the clinical practice day to day, which then we can advocate on behalf of because of what we're seeing. For example, there's issues related to denials for payment on certain things, like we were talking about with IGRT payments or with simulation payments. These kind of denials, then you can help advocate. Another thing that you see is with prior authorization. Oftentimes, you know, you have to try to do two plans, an IMRT plan and a 3D plan, try to get somebody on the phone to get a peer review when something's denied. And so dealing with prior authorization can delay care. And so because of that, you see these things happening to patients. So then when you talk to your legislators, you can actually have personal stories that you can convey. For example, I had spoken to Ricardin a couple weeks ago, and I specifically gave a story about a rectal cancer patient whose treatment was delayed because of prior authorization issues related to IMRT denials. And so you have these stories in hand, which are much more personal and powerful and impactful than just talking abstractly. And so that's a good way that you can use it.
Do you have to have documentation for these stories? Or just a verbal relay is enough?
Well, you're not saying the patient's name.
Okay.
You're not giving any HIPAA information.
Mm-hmm. All right, let's, Dr. Wallner, would you like to add something to it?
I'm the poor one to ask, because my days are spent in support of clinical practice, but not anymore in day-to-day clinical practice. So my life is advocacy and quality measures and working with high-level payment policy now.
Right. Moving on to the next one. What is your perspective and how to stay involved in advocacy during the COVID-19 pandemic?
Amar, why don't you take that?
Dr. Rewari.
So, I mean, I think one of the things you can do is you can, well, everything's done virtual now, right? So like when we have these meetings with people, you can have virtually. So nothing's preventing you from, you don't have to have a face-to-face interaction to still be able to advocate. The other thing is you can focus on issues related to the COVID-19 pandemic. You know, you can focus on issues related to the Provider Relief Fund, the CARES Act. You could, the PPP loans, the telemedicine, how the economic stability of your practice. So there's all these issues you can focus on that specifically relate to COVID-19 when you do advocacy.
So we have a question from the audience that talks about something similar to this COVID-19. According to Austin, many Hill Day policy fellowships have been canceled due to COVID-19. Because of that, how would you have any thoughts on what the trainees should do since these fellowships have been canceled?
So, the ASTRO Health Policy Fellowship application is going to be coming out next week. And so that's still a fellowship that's going to be relevant. It's a one-year fellowship. You end up actually observing and seeing the whole CPT RUC process and learning all these issues that I spoke about. I think if somebody's interested, I think it's a very valuable fellowship. Because, like I said, the committee, the subcommittee where all these codes and everything comes out of sits in ASTRO. And so the only way you can observe that is through that fellowship because it's a confidential thing. So you can't see the inner discussions about how these codes come about. Right now, ACR's version of that focuses on radiology codes. And so what happens is you won't get to see the radiation side of that, but it's a good fellowship. So that's still there. And I'm not sure how different advocacy days will be handled, if it'll be virtual or something like that eventually, but I imagine eventually there'll probably be virtual advocacy days. So.
Okay. So we have a Canadian resident too in our audience, and he is asking about the political realities of being a resident, and should he wait until he becomes an attending? Is it safer to talk about advocacy when you reach that stage, or is it okay to start from an earlier phase in life?
Well, this is Paul Wallner, I can take that. I think it's never too soon to start. If you feel passionate about a particular issue and you want to get involved with advocacy, we've had residents who have done a spectacularly good job just based on their interest and their motivation. It's never too soon to get involved. I think the issue of advocacy during the COVID-19 pandemic is tough because I wish my crystal ball were working and I could tell you what life will look like on the other side. But as everyone knows, Congress is doing most of its work virtually now. Many of the legislators and regulators are working virtually. I have discussions with, I do a lot of ALJ appeals for 21st Century Oncology, third level denial appeals. All of the administrative law judges are working from home now. So advocacy, a lot of these legislators and staff members are still in their communities. They're still doing some fundraising, very often virtually, or they're doing it with social distancing. There's no question that COVID-19 has made everything different and more difficult, but you still can get involved, and it's still important to put your name out there and your interest out there.
Right. So regarding the issue of this prior authorization, what do you think are some of the obstacles related to efficient prior authorization and how radiation oncology advocacy is helping with that? Dr. Rewari.
So I mean, some of the obstacles is like I said, one of the big ones is delay in patient care, right? So if you have somebody who has a definitive treatment that needs to be done, any delay is critical. Cervical cancer, let's say you're trying to get an IMRT plan for cervical cancer, you don't want to delay these patients. And if they're not approving it, it's a problem. There's staff time and that goes into creating multiple plans. And so the time went into creating multiple plans on one patient, but also delay care on other patients. Oftentimes the people you get to make these decisions on a peer review aren't radiation oncologists. You first have to go through some screening nurse or NP or PA who doesn't know about radiation oncology. And then oftentimes when you contact them, they'll say they'll call you back, and then they call you back. They purposely call at like 11:59 p.m. when they know you're about to leave clinic to get lunch or something. And so your phone will go to the answering service. They'll call you at the end of the day. There's oftentimes these strategies that are done. So this way they can say that they contacted you and that you were unavailable, and then the denial stays. You know, the majority of denials, initial denials, are overturned after a peer-to-peer. And so the whole idea that prior authorization is preventing inappropriate medicine is a fallacy. While there are some people who are doing inappropriate medicine, it's really more denial and then hope that an office or a physician is too busy to be able to do a peer-to-peer and fight it. And so then the denial will stay and they'll keep things. Because if the majority are being overturned, clearly it wasn't bad medicine. It was just just because they were using nomographs and not, you know, clinical judgment, which when you have the peer-to-peer gets overruled. So.
This is Paul. I'll make another comment about prior authorization. This is one area where when you go to legislators and regulators, I think it's critical that you really do have your numbers, because they will invariably ask you what is the real extent of the problem. And you can't say a lot, or I've had many patients, they want to know exactly. And I've suggested to people who ask me about this that you absolutely document, obviously not with HIPAA related data or patient specific data, but you have to document every instance of a problem such as Dr. Rewari just mentioned, so that when you go to them, you can say, here, I've had this 20 times in the last 2 months, and this is unacceptable, and it's delayed patient care, and I can show you that a patient with head and neck cancer is delayed for 3 weeks. It impacts their outcomes. That's the kind of information that legislators and regulators live by, not by generalities.
Last question for Dr. Wallner. During the course of career development, when is a good time to consider taking a break, to consider full-time advocacy opportunities like the White House Fellowship?
Whenever it works for you. For some people, you know, it seems that the natural time is after medical school or after a residency. For some people, it's effectively a sabbatical-like break. I know that my good friend Howard Sandler, who's chair at Cedars-Sinai in Los Angeles, took a break a year or two ago and worked at the FDA for 6 months. People who can do that really then become very involved in healthcare reform and in advocacy, because then these regulators know them by name. If you can do that, if you can take a couple of months off, even it doesn't have to be a year, if it can be, you know, 2, 3, 4 months, and work at some of these agencies, they get to know you, you get to know them, you get to know the intricacies of how these operations work. It's critical, but whenever it works for you from a career perspective and a family perspective, it's not always easy. I understand that.
So for everyone in the audience who's asking how they can contribute during their in-training years, there are a bunch of resources that are listed in the PowerPoints, which will be available, as we mentioned earlier, within 48 to 72 hours. I would like to thank our speakers, Dr. Paul Wallner and Dr. Amar Rewari, our entire ACR webinar team, Dr. Lashes and Teresa Powell, without whom it would not have been possible to conduct this, Dr. Arya Amini and Dr. William Small, and all of the participants who are here with us. So if you would like to, I would encourage everybody to go ahead and check this Radiation Oncology webinar series. It's under the tab of Radiation Oncology resources. There are many good things out there for all of us. And there's 2 tabs, and let's move on. And again, stay tuned for our next webinar, which is going to be on November 4th. And then we'll announce the 2021 cycles. If you want to follow any of us on social media, the Twitter handles are right there for you. And any questions can be directed at the contact information just listed here on the website. Thank you so much. It's a wonderful experience to be with ACR and to talk to everyone using this platform. Thank you.
Thank you.